Let's break down the CLSI M100 standards, following the path from an isolated organism all the way to the final clinical report. It all begins with selecting the right agents for testing. This is a critical decision, a collaboration between the lab and the stewardship team that really sets the foundation for everything that follows. So, CLSI organizes this with a tiered system. Tier 1 agents are your primary, go-to drugs that get reported routinely. Tiers 2 and 3 are also tested, but their reporting is often cascaded to push clinicians toward narrower options first. And then you have Tier 4, which is purely by request. So how are these agents actually chosen? Well, it's not arbitrary. It's a careful balancing act, weighing clinical efficacy against local resistance patterns, stewardship goals, and of course, practical things like FDA indications and cost. Okay, tests are done. Now comes the interpretation. This is where the core definitions, breakpoints, and interpretive categories become absolutely essential for making the right clinical call. The breakpoint is the key number here. It's the specific MIC or zone diameter that sorts an organism into a category. And it's so important to remember, these aren't just arbitrary lab values. They're set because they are strong predictors of what's going to happen in the patient. And those breakpoints feed directly into these categories. Susceptible is pretty straightforward. Standard dose should work. Susceptible dose-dependent, or SDD, is a critical one. It tells you a higher dose is necessary for efficacy. Intermediate serves as a buffer, and resistant, of course, predicts likely failure. Non-susceptible is simply what you use when there's no defined resistant breakpoint. So we have our interpretation, but how we report that information is just as critical. The M100 standards are really designed to use reporting as a tool to guide smart antimicrobial use. There are two key strategies for this. You have selective reporting, which is based on static criteria. A classic example is only reporting nitrofurantoin for urine isolates. Then there's cascade reporting, which is dynamic. It's based on the organism's actual results, only revealing broader drugs when the narrower ones won't work. And this logic of cascade reporting is really a core tenet of good stewardship. By holding back the results for broader Tier 2 or 3 agents, the report naturally nudges the clinician toward the narrower Tier 1 drug, unless there's documented resistance. Let's look at a real-world case here. In example B for Klebsiella pneumoniae, if the isolate is resistant to the Tier 1 drug, ceftriaxone, that triggers the cascade to then report Tier 2 agents like cefepime or the carbapenems. And if it's resistant to those as well, only then do you unmask the Tier 3 agents. It's a very deliberate, structured escalation. Beyond the routine workup, M100 also outlines some advanced testing scenarios. We're talking about supplemental, surrogate, and equivalent tests, which are all about detecting specific resistance mechanisms or just making the lab more efficient. Supplemental tests give you that extra layer of critical information. The D test for inducible clindamycin resistance is a required one for staph and strep. You have to do it before reporting clindamycin susceptible if you see erythromycin resistance. Others, like ESBL or carbapenemase tests, might be optional, but they provide invaluable data for treatment and infection control. Now, surrogate testing, this is all about working smarter. The sulfoxidin screen is the perfect example. It's the standard for predicting MECA-mediated oxacillin resistance in staph. Similarly, a simple oxacillin disc can predict penicillin susceptibility in S. pneumoniae, letting you skip a full MIC if the zone is big enough. And finally, there's equivalent agent testing. Basically, if you see an OR in the CLSI tables, like cefotaxime or ceftriaxone for Enterobacterales, it means the results are interchangeable. You can test one and confidently report the result for the other, which cuts down on redundant work. All right, let's move on to what might be the single most important part of the guidelines, what the lab must not report. These are explicit warnings to stop the use of drugs that might look good on a plate but are clinically useless. CLSI couldn't be any clearer here. This quote says it all. There are specific bug-drug combos that can look susceptible in the lab but will fail in a patient. They must never, ever be reported as susceptible. And here are some of the classic examples. You never report first or second-gen cephalosporins for Salmonella or Shigella. And for Enterococcus, reporting susceptibility to cephalosporins, clindamycin, or Bactrim is absolutely off the table no matter what the raw data says. There's also a special do not report list for any isolate from CSF.
This includes a whole range of drugs, most oral agents, certain cephalosporins, specific carbapenems like ertapenem, clindamycin, and others that simply don't penetrate the central nervous system well enough to treat meningitis effectively.
So when you step back, you see these aren't just rules for the lab. They're direct interventions for patient safety and public health. The real question for all of us is this: how is the strategic application of these M100 standards in our own labs directly impacting patient outcomes and helping in the fight against antimicrobial resistance?